Good morning, everyone. We are very happy to have everyone with us this morning for our first Department of Surgery Grand Rounds for 2021. We have a very honored guest with us this morning. Really not a guest, he's our faculty, of course, and has been for quite some time, but I think we're really honored to have him with us this morning, Dr. Benjamin Anderson. I will give you some background on his bio, which I think we all know him well, but I'll make sure that you know what he's been up to recently. So I think we all know Dr. Anderson. He holds a dual professorship, both in the Department of Surgery and also in the Department of Global Health and Medicine at the University of Washington. And he has been very, very productive over the years through both of those adventures. He was the director of the breast health clinic at the University of Washington and the SCCA for over 20 years through 2018. And I think so many of us know him through that clinically and his work to really advance oncoplastic and breast conserving therapy for breast cancer. He's been the president in the past of the American Society of Breast Disease and also was a vice chair for the NCCN for their breast panel for over 7 years. But I think we all know that Dr. Anderson is probably more recognized for all of the international work he has done. Through his joint appointments, he developed the Breast Health Global Initiative, which has really worked tirelessly to advance breast cancer care globally, especially in low and middle income countries. And through that work, he has achieved and received many honors. Both from ASCO and from the Washington Global Health Alliance. Most recently, Dr. Anderson has chaired the Breast Cancer Initiative 2.5, which is working to avert breast cancer deaths for greater than 2.5 million women by 2040. And in 2020, he joined the World Health Organization to help develop and launch their Global Breast Cancer Initiative. So Dr. Anderson, it is a great honor and pleasure to have us with you this morning.
Well, thank you very much, Deb. That was a really kind introduction. And I just want to thank everybody for being here today. Before we go, as someone who's been working away from the clinic, and I'm watching the news and seeing just how difficult the situation is, I want to thank everybody who's in the clinic and doing this hard work. I can see how terribly challenging it all is. I also want to thank the Department of Surgery, Doug, David, and my wonderful surgical partners for backing me, and for the mentorship of Dr. Pellegrini in the work that I'm going to be talking about now. So the Global Breast Cancer Initiative is this program that we're launching from WHO. I'm working as a consultant for WHO in the development of that. The reason that's happening is because I've chaired the Breast Health Global Initiative since 2002, and we've developed principles that are now being applied in these areas. What I'd like to do is walk you through how we got to this place so that the framework for understanding the Global Breast Cancer Initiative can make sense. Let's begin by looking at some of the data about breast cancer. Breast cancer is the most common cancer among women. It's the most prevalent cancer among women around the world. It is the most likely reason that a woman would die of cancer. There actually are more disability-adjusted life years lost by women globally than to any other cancer. The majority of breast cancer cases already occur in low and middle income countries, over 50%. By 2040, 60% of the projected 3 million new breast cancer cases and 70% of the 1 million new annual deaths will be in low and middle income countries. And there's this very broad range in terms of how we do with breast cancer. In our part of the world, the 5-year survival is 90%, but in India, it's 66%, and in South Africa, it's 40%. So there's this huge diversity, this disparity that we see globally, which of course is very sad. But on the other hand, it speaks to an opportunity because it shows that there are things that can be done. And the question is, how do we translate what we already know works into environments that have fewer resources? A recent publication that came out on December 23rd from Sub-Saharan Africa, this is the IARC's ABCDO project, looks at breast cancer deaths in 5 Sub-Saharan African countries. This is really novel data that's come out. But from this study, we learned that half of the breast cancer deaths are occurring in women under the age of 50. And if you look at every 100 maternal deaths That produces 210 maternal orphans. So there really is a real generational impact that is social as well as fiscal on these countries. We need to be addressing this today. So here we're looking at breast cancer incidence. It's often said, oh, well, isn't breast cancer really just a problem of high-income countries? And that because the incidence is higher in the, as illustrated by the dark colors here. That's because we look for cancers. Screening is a component of that. But when we look at mortality, we see the flip of this. We see that the highest mortality rates, this is age adjusted, that the highest mortality rates are in these other regions of the world. When we look at prevalence, again, the prevalence follows the incidence, but it also speaks to how we do better with these breast cancer cases. It's often said that in sub-Saharan Africa, gosh, we see a lot more cancers in younger women, and suggesting that maybe the distribution of the disease is somehow biologically different. But actually, the highest prevalence of breast cancer in women under the age of 40 is in our part of the world. So we actually just have more cancers at all ages, including these youngest age groups. So here you're looking at the pattern of incidence. Breast cancer is, by incidence, has been head and shoulders above these other cancers. That is a biological statement that needs to be understood. But of course, incidence rose with mammographic screening. When we look at males, when we began doing screening for prostate cancer with PSA, we saw this big peak. Now, the reason we are no longer recommending routine PSA screening is that this did not translate to a mortality benefit. That is different from mammographic screening. Here's a nice study from Francis Verdial where we looked at how mammography changed the demographics of breast cancer. And what you can see is that when we started doing mammographic screening, early stage disease went way up. What's very interesting is that it was not a corresponding amount of late stage disease that decreased. There has been a decrease, but much more gradual. So you need to understand that when we do these screening tests, it does change the picture. It changes the demographics. And we need to anticipate this as we look at improving opportunities. But the really important point is that after we started doing screening and early detection efforts, it was about 8 years later that we then started to see this drop in breast cancer mortality. And it's been dropping by about 2% per year since that time. There actually has been a 40% decrease in breast cancer mortality from 1980 to the present time. And so we're definitely doing something right. And the question is, how do we translate this to other parts of the world? What our evidence tells us is it is a combination of the early detection strategies. And that does not equate with screening. We'll talk about that in a minute, but early detection strategies that is combined with the treatment that follows this. So it's actually not early detection that saves lives, it's early treatment that saves lives. You have to link those two in order to make this work. Our modeling shows this, and this is how we need to move forward with implementation. So I'd like to take a moment to talk about the differences between screening and early diagnosis, because this is often not completely understood. Ideally, we would prevent breast cancers or any cancer by eliminating the sources, decreasing the risk factors. And there's a variety of reasons why that would not address the majority of breast cancer cases that we see today. But early detection is this broad umbrella under which we find cancer at earlier stages. That's when cure is more likely and when treatment is not only more effective, but more feasible. Early diagnosis is when we're looking for cancers that are symptomatic. Those are the palpable lumps. Those are the findings that the woman appreciates or that someone appreciates on a clinical exam. Screening is this subset where you're looking at asymptomatic individuals. We don't know if they have cancer. We're going to use a test of some sort to identify those that are in this case. And that distinction is very important from a health systems level. Historically, people have said, oh, well, you know, it's screening mammography. That must be the answer. It's this imaging test that's saving everything and changing everything. And that is overly simplistic. It is certainly true that screening has made major impact. And when we look at the data, there is a reduction of about 20% in mortality overall with the majority of screening trials that were done. And that's why we recommend mammographic screening today. but not all of the trials showed this benefit. The Canadian screening trials were a notable exception that have caused a lot of controversy, because with 25 years of follow-up, they never did see a mortality benefit in Canada with the use of these trials, with the use of screening mammography in comparison to the control arm where routine mammographic screening was not recommended. This led to a lot of finger pointing and saying, well, maybe the Canadians really don't know how to do mammograms. What is the issue here? But actually, when you look at the data from the Canadian trial, what you can see is that in that control arm, the women that did not undergo routine screening, they were still pretty good at finding small cancers, the median tumor size being 2 centimeters. So the argument that we would make is actually, instead of focusing on what was wrong with the mammography arm, the question is, what did they do in the control arm? Because that's what we want to translate to limited resource environments. WHO back in 2010 said mammographic screening was a, quote, best buy because it avoided about 19% of cancers. However, they also noted it's impractical and unaffordable for most low and middle income countries. And so that we have to look at alternate strategies, recognizing that it's not a one size fits all solution. Consider the study that we did in Indonesia. So that this was a study that was set up in which both clinical exams and mammographic screening was performed. They trained people on how to do clinical exam. They invited women to come in for having this dual evaluation. They did questionnaires, and then they looked at the outcomes from this. Very important to note, of the 1,179 women that underwent both mammographic and clinical breast examination, a quarter of them needed a diagnostic workup. This is usually overlooked. So there's a lot of people that need to have diagnostic workups when we do these interventions, and those take resources. But actually, when they ultimately, how many cancers did they find? There were 14 cancers found, and this is about what we see with screening mammography, 1.2%. So about 1,179 women to find 14 cancers, that's a big investment. But in this previously unscreened population, what you can see is that 13 of the 14 cancers were appreciated on clinical exam. This doesn't mean mammography doesn't work. What this means is that it's not the first mammogram that's important. It is down the road. It's the repeated mammograms where we see these benefits. And the initial test is clinical evaluation that needs to be performed. And this is why WHO has made this distinction between focusing on versus early diagnosis, where there's a smaller group of women, and the question is, how do we get them to come in with early stage disease? These efforts were led by Dr. Andre Obawi, who is the cancer lead at WHO and has been a fabulous colleague working there. And he made his way, as everybody here knows, is a little bit older. Andre came right through and was a general surgery resident, graduated in 2013. Consider this example of India, because we've debated, does clinical breast exam work? What do we see? Well, actually in India, where there hasn't been screening, there is an ongoing randomized trial, 2 of them actually, in which they're randomized to education versus clinical breast examination. And what's really interesting about the trial, it does show downstaging. In fact, the pattern looks very similar to what we see with mammographic screening. So what you can see is when you do routine clinical exams in unscreened populations, the incidence of cancer goes up, particularly upper right, the early stage disease. So the patterns are looking right for clinical evaluation. And that's why we need to continue to focus on this. Here's an example from Peru. Dr. Anya Romanoff, who was actually a Fogarty Fellow at the University of Washington, coming to us in the Department of Global Health from Mount Sinai, where she's now a faculty member in breast surgery in New York. She did a study in Peru where we evaluated all of the women who came through for a 3-month period with a new cancer diagnosis. The outcomes of this study were delay in diagnosis and stage at presentation. The stunning finding of this trial was that over 407 days was delay from what the initial symptoms to treatment. And the majority of that time was actually a health systems delay. But here's an important point. 93% of the women found the cancers themselves. So we must be very cautious in saying, oh, self-exam doesn't work. Teaching self-exam as opposed to educating women and allowing them to detect cancers, that's the distinction that's been made. But actually, with these very significant delays, what they found was when women had a clinical breast exam, when they had somebody in the past had done a clinical exam, those women had decreased delay, so fewer women waited longer than 90 days, and they had earlier stage at diagnosis. And so the point of this is we tend to think very narrowly about our test. Okay, clinical breast exam, it's how good are my fingers at detecting it, not recognizing within health systems, there's a much broader implication. Actually, there's an educational component to doing clinical breast examination because we're helping women understand what is it that we're looking for. And so we must not throw out the baby with the bathwater, especially in settings where mammographic screening is not affordable. When we looked at multivariate analysis, what you can see is that that clinical breast examination was an independent predictor of favorable outcome. And even when controlling for the household income and insurance source. So this is not a biased issue, it's really about the clinical exam. And that's why we must continue to use this clinically, which is kind of obvious to surgeons who do the work that we do. What I'd like to move into now is a discussion of resource stratification and implementation, because this is the core work that the Breast Health Global Initiative triggered with our initial studies going back to 2002. What we did was we held a total of 6 global summits, the first being back in 2002 and the most recent being in 2018. And what we did was we took on these different topics of what are the nature of these health disparities, how does this work, and we developed this concept of resource stratification. This is actually based on the NCCN model. We brought together experts from high-income countries and low and middle-income countries, and we used this consensus evaluation of existing evidence. And the core approach to this was actually not the meeting. The core outcome were the publications. And I would say that in retrospect, that was a really good idea because it was the getting this into the peer literature that really propagated where this went forward. But this concept of resource stratification is in recognizing that when we do our guidelines in high-income countries, when we look at the NCCN guidelines that we use every day or ASCO guidelines or others, what those are scientific exercises to ask, well, if we have all the tools, how do we put them together in the best way to make outcome? The problem with them is they don't provide any prioritization. They don't say, well, what comes before what? So what BHGI did was say, look, we can lay this out into 4 levels. Basic level resources are those you cannot do without. Breast surgery would be an example for breast cancer today. Limited level resources would be those outcomes, those resources that will make major improvements in outcomes like survival. Most of our drug therapies fit in this level. Enhanced level we defined as those that may not necessarily improve survival, but will improve outcome. So doing breast conserving surgery, doing a lumpectomy with radiation rather than mastectomy. Women don't live longer because we do that. Our evidence is clear on that, but it does improve the participation because most women would prefer to preserve their breasts. Maximal level, we said, well, actually there's some resources not to focus on, and that it's this prioritization scheme that laid this out. NCCN has been involved in BHGI since the very beginning. Bob Carlson chaired our first treatment panel that we did, and he of course is now the CEO of NCCN. And what NCCN did was they created resource stratification of the guidelines. So there's a methodology that they used in which that same 3-tiered approach, recognizing there's some resources you do not focus on at that enhanced level. Breast MRI would be an example of that. At the core level, they used core rather than limited in their terminology. There's another level that are not going to make those major improvements in survival. And then there's the basic level that you can't do without. Now, it's important to understand that there are some areas where we're going to substitute what we do. So if you don't have CT scanning, actually we used to do quite well with chest x-rays, abdominal ultrasound, plain films. And so being able to think this through in an evidence-based way is a core value. And so if you take away all of those resources, these are the fundamental basic level resources that you need. This is not an endorsement of substandard care. This is a prioritization scheme that helps you know how to build. And that is really fundamental. But that resource stratification approach is a little hard to apply. And that's what led NCCN to say, we're going to go to the next level of creating harmonized guidelines. So NCCN, working together with the American Cancer Society, the Clinton Health Foundation, and IBM, pulled together these representatives from different African countries. And what the Africans did was they said, we looked at the resource stratification, we looked at our general guidelines, here is what is standard for us in sub-Saharan Africa. And so they created their own model of this. And what was so striking to see when this was presented in Paris in 2018 was how the Africans who were presenting it said, these are our NCCN guidelines. And that is really a core value in making this work. The harmonized guidelines have expanded to cover 85% of all of the cancers that are happening. Here's another example of Peru that says, okay, now you've got the harmonized guidelines, how are you then going to implement them? In our last global summit in 2018, we promoted this concept of phased implementation. You go in steps. Yes, you begin with guidelines, but then you have to sort out how are we going to do this in a stepwise fashion. You need to be able to manage palpable disease before mammographic screening is relevant. And that's why we need to do situation analyses to understand what is happening in each of these countries today. It's not sitting in a room somewhere, it's actually making these differences happen. And so in Peru, and this is where Anya Romanoff's study was based, this idea of, well, we are going to do clinical evaluation at the health systems level, go to the district hospital where tissue sampling can happen, and then that's how we decide who goes to the cancer center. So this idea that we have to think about systematic triage, this is fundamental to improving healthcare systems. But we have to design studies that will actually measure these outcomes in meaningful ways. BHGI supported a cluster randomized trial in Colombia. And this was an intervention trial in which the intervention was not on the women, the intervention was on the healthcare system. So in this cluster randomized way, they provided education in some clinics where they educated the providers and the healthcare system about how do we do screening, because they are ready to do mammographic screening, versus the control group in which they didn't yet do those. And they compared these outcomes. It was a sequential evaluation. So it's a very cleverly designed study in which they observed in the intervention group, there were more cancers that were found earlier, and there were more cancers that were later when they didn't have that education. But an unanticipated finding of that study was that more women successfully underwent breast conservation. As in comparison to those, more had mastectomy in that absence. This trial cost a BHGI total of $40,000, which is such a tiny amount, and it points out doing this research is very affordable. Now, so therefore, we have to think, as we're developing these strategies, we really have to think about the healthcare frameworks in which we're working, because it's great for us in academics to be sitting and doing the analysis, but this has to be applied in the real world. And that's where WHO lives. So WHO, it's important to understand, they're not a research institution, they're a policy organization. And there's a lot of misunderstandings about what does WHO do and how do they work. Actually, Geneva, which is the base, Geneva is not where decisions are made. That's where normative guidance comes from. But actually, it's out at it is a reverse strategy in which the main drivers are in country. It's the member states where WHO has this impact. So WHO follows what they are instructed to do, and ultimately comes from the United Nations. A very important step that took place at the UN was in 2011 when they had this high-level meeting. And what they said at this meeting was, okay, WHO, you've been focused on infectious disease, you've done a great job, it's excellent, but now we need you to focus on non-communicable diseases, NCDs, because they are becoming the dominant problem. The NCDs are cardiovascular disease, lung disease, diabetes, and cancer. Those are the big four. And so WHO, you need to retool and make sure that you're addressing this. And this provides a structure. So instead of just saying, okay, well, we've got these essential medicines listed, an example of what are the medicines that need to be provided, we have to think about how to actually implement this in organized fashions. Because you see, where they had been focused with infectious disease or trauma, those tend to be single interventions. Somebody comes in, they need a vaccine. Somebody is injured and they have to come to the hospital to be treated. What that doesn't necessarily set up for is longitudinal care. How do we manage patients over time? And if you think about whether it's hypertension or diabetes or cancer, you have to follow them over time. So there's an infrastructure that goes with that. That's part of the NCD framework. So in Geneva, this has been the driver, the headquarters for this. I'm actually working today from Rochester, Minnesota, rather than Geneva, and that's because of the travel bans that have not taken place, but I've been coordinating from here where I'm only 7 hours off rather than 9 hours off from Geneva. But a really important step took place in 2017, and that was the Cancer Control Resolution, in which WHO was called on to use resource stratified guidance for implementing cancer changes. So in this resolution, not only is there resource stratification that's mentioned, but cost effectiveness. We actually do need to think about what can we realistically do with the strengths that we have. And this needs to be harmonized with technical assistance. And so we need to work with partner organizations to make all of this happen. Andrea Bawe was a very important driver in getting this resolution through, and is certainly a reason that I'm collaborating with WHO today. But from a system standpoint, we have to recognize that there are three groups here. There's us, the clinical healthcare workers and providers. Yep, that's where we do this work. And then there's government. It's the policymakers that actually decide. And we certainly have seen historically that our government doesn't necessarily listen very closely to the healthcare industry when we provide guidance. And so but who do they listen to? Well, actually civil society, that the non-governmental organizations, it's the patients, they're the voters, they're the ones that drive what it is that we're seeing. So it is this triad. How do we talk to all three organizations together? One of the tools that BHGI and collaborating organizations developed were knowledge summaries, where we have these documents that are like a Rosetta Stone, where it talks about what is it that needs to be done in understandable language and what are the policies that go with this, so that everyone is reading from the same card. But we really have to think about situation analysis. Tanzania is a situation analysis that we were invited to do by Komen, in which we looked at is their healthcare system working. Tanzania is really a wonderful country in East Africa. And what is very common throughout sub-Saharan Africa and Latin America as well, this pyramidal structure, where we have the primary health clinics that refer to the district hospitals, that then refer to the regional hospitals, to the zonal and national. So it's a 5-tier system within Tanzania. It's the national hospitals where the majority of the cancer care takes place. What we learned was that while the patients accessed the system at that primary care level, needle biopsies were not available until level 4. And so you see, the only way that the woman would actually get a needle biopsy diagnosis is by being referred 3 times to get up to the zonal hospital. And so the standard statement is, oh, well, in sub-Saharan Africa, we don't have so many cancers, but they're really bad. And that tends to lead us to say, well, biologically, is there something different about the cancer in Africa as opposed to the US? That may be true. But what this shows is this is a systems issue. The system was actually creating a filter that was blocking patients to get through. Who's going to make it all the way to level 4? It's the patients with the most aggressive disease, who are clinically the most difficult cases. Who are they? The young women. And so you see that we have to be, there's no way that The government would know about this because they haven't had a system that's been set up to address cancer. And what it creates is this balance that we have to address. There's some services we need to centralize to improve quality. So our more challenging issues, this is why cancer centers are so important. But on the other hand, we have to decentralize other activities to improve access. So the women enter the system at accessible areas, and something has to happen in the middle. We're in the middle of a study that we're about to publish in which we are looking at how has this worked. And what we can see is the two independent predictors of improved outcome in breast cancer are universal health coverage, that the cancer care is affordable, and number of cancer centers, public cancer centers per capita of cancer patients. So you need to have cancer centers and you need to have funding in order to make this true. And folks, this is the same issue in America in our underserved communities. This is not remotely unique to low and middle income countries. So finally, I'd like to talk about the Global Breast Cancer Initiative. This is the program that I've been working with our team on developing, because this is the framework through which WHO will be doing this work. We're going to be launching this program in the next quarter, and it has work that is going to be developed over this next period of time with a target of October of 2021, when we'll be, that's Breast Cancer Awareness Month, where we're going to be showing the results of our work. The objective of the Global Breast Cancer Initiative is to reduce global breast cancer mortality by 2.5% per year. Mortality reduction 2.5% by year, which I'll show you the math in a minute. If we were successful in that aspirational goal, that would avert 2.5 million breast cancer deaths globally between the years 2020 and 2040. There are three pillars to the Global Breast Cancer Initiative. The first is health promotion for early detection. The second is timely breast diagnostics. And the third is comprehensive breast cancer management. And the strategy here is the integration of what we've learned from our public health sciences and the clinical medicine that we do every day. It's really the marriage between PHS work and clinical work through which we're going to make this happen. And for those that are interested in global health, this is a good reason to, if you're going to do the research track, do that MPH. Understand the public health sciences side so that you can translate what you know works in the clinic into environments that go beyond that. So here you're looking at mortality curves for a series of mostly high-income countries. And what you can see is that pattern that we saw, rising incidence with early detection, peaking in the 80s to 90s, and then this drop of between 2 and 4% per year. So that 2.5% per year target is not, that's actually been done. But the problem is we haven't seen that yet in middle income countries where we actually have data. So how do we translate what happens on the left to what's happening on the right? That is the fundamental strategy. So now we're looking at projected global breast cancer survival for women under the age of 70. The reason we're looking at the age of 70 is WHO has the assignment of avoiding premature mortality, which is deaths before the age of 70. And so what you can see is the projected breast cancer mortality will increase by 33% by 2040. That's if there are no changes in the demographics today. If we could just reduce mortality by 1% per year in these women, that would flatten the curve. So this is all about curve flattening. How do we can at least flatten it if we could get to 1% per year annual reductions. But if we go to 1.5 or 2 or 2.5%, that's where we get the curves that are starting to look like what actually have been achieved. That 30% reduction, that is part of the Sustainable Development Goals, the SDGs, that's the assignment that WHO has for non-communicable diseases. So the point here is, this is doable. It can be done. The question is how. Now, where did we get this 2.5 million lives saved? This is just adding the number of deaths that are there. It's 2.5 million lives that would be saved with that 2.5% reduction. That is of the 10 million breast cancer deaths that are projected to occur between 2020 and 2040. So that's the math. That's why we're talking about it. But the truth is, when we address breast cancer, we do it one patient at a time, right? And there are these 3 phases. This is what we published in 2000 from the 2018 summit. So there's the patient phase where she comes in either because she has breast symptoms or she's had a screening study. And it's important to recognize that even in mature mammographic screening populations, 60% of the cancers in that most heavily screened group is found in the screening, meaning that 40% are clinically detected. So what we do in the breast health clinic, how we work up palpable lumps, this is an absolute fundamental value. It's that middle phase, the workup. It's the clinical evaluation, imaging, tissue sampling, and pathology. That loop is how we diagnose who has cancer versus who has benign findings. And remember from what we were talking about earlier, that's a 10-to-1 ratio. And that's why this middle system really has to be thought through. The treatment then, once we know they have cancer, we know some patients warrant curative therapy. Others, the disease is going to be too advanced and we should focus on palliative care. This is the system, and it's absolutely the same whether one is in Seattle or Nairobi. And so this is because this is about the biology of the disease. On this early detection side, that first pillar is health promotion for early detection. Our target is for 60% of the invasive cancers to be stage 1 or 2 at diagnosis. We're picking that number because when we are looking at the current data, every country that has achieved those curves that go down have at least 60% of their invasive cancers as stage 1 or 2. Health literacy of the public, so educating women. This is an example for Peru. We want them to understand breast health. We also want to link this to existing programs. So cervical cancer screening is recommended by WHO for all women from somewhere to occur between ages 30 to 49. So providing health literacy to women about general health, including breast health, as part of the cervical cancer program, that's a goal. But we also have to educate the providers because they need to recognize early breast cancer when they come from systems where it's not been recognized before. WHO has these educational modules targeting non-communicable disease. And what we do want to do is create a clinical breast assessment course. Folks, this is exactly what we do in the breast health clinic. This is how do you work up a lump? What is disease versus what is benign? And providing these educational modules using virtual education as a core strategy. And so one of our demonstration projects is going to be in Latin America for providing this clinical breast education. But timely diagnosis, as we saw in the example of Peru, is really important. The target is to be able to do a diagnostic workup within 60 days. The reason 60 days is the target is because at 90 days or 3 months, that's when we start to see decrements in breast cancer survival. So this concept of creating rapid diagnostic units where we do imaging, generally beginning with ultrasound, and tissue sampling with pathology, this is all doable. It's generally, the issue is in part about availability of resources, but it often has to do with organization. How do we make it so that the women have access to these units in ways that are feasible? Pathology is a core requirement, and it's actually where we started with the resource stratification in the beginning when we learned that it was taking 6 months to make a pathology diagnosis. So having tissue pathology services is really important. Here we use H&E staining and immunohistochemistry. Immunohistochemistry is really complicated, and it's based on antibodies. So the use of leapfrog technology is an important area. There's now work with PCR, which turns out to be affordable and feasible and can use the same tools that are using PCR for infectious disease. This type of technology has the potential to really revolutionize what's happening. But we have to think again from the patient systems perspective. And what we know throughout our system, patient navigation is absolutely essential. We have to be able to manage the patient getting through this system. We don't just send them over there and hope it works out. Patient navigation, the payment, we really make difference when we have patient navigators, whether it be lay navigators or nurse navigators. This is fundamental to getting them through these systems. Now, what about the treatment side? How are we going to make this happen? You need to have centralized cancer centers, whether that be in Peru. This is in Trujillo, the North Regional Cancer Center in northern Peru, or Tata Memorial, which is one of the most fabulous cancer centers in the world. It's in Mumbai, India. What is it that we do in those centers? And this is about comprehensive cancer treatment. Ideally, we would want 80% of all patients with cancer, this is most certainly not limited to breast cancer, to have a multimodality treatment based upon evidence-based guidelines, and to make it all the way through treatment without abandonment. It's actually not the first dose of chemotherapy that matters, it's the last dose of chemotherapy. How do we get them all the way through without leaving, understanding that there are all of these obstacles to make that happen? So the multidisciplinary treatment planning, the patient navigation, and systematic assessment of how this is going to work, that implementation research, this is really fundamental. It can be hard to convince ministries why they would invest in research. It's like, well, if we can't afford the care, why would we invest in measuring these outcomes? But that's like building a car without a speedometer. At some point, that speedometer or a gas gauge, you really need that gas gauge. It's not too expensive. But we can't forget about the patients after they're done with treatment. They have to reintegrate into their community, minimizing the financial toxicity. And so that follow-up at the primary care level, with survivorship and palliative care being available, these are fundamental needs. And here, we're really not talking about breast cancer in specific. This is why breast cancer is an index malignancy. If we could do breast cancer, there are a lot of cancers that we can do. And this is really fundamental to how we're going to approach this. So one of the demonstration projects that we're also looking at launching is a study in Zambia. And our goal is to make a longitudinal system work. So women coming in with palpable lumps need to have tissue sampling. We need to know if their tumors are estrogen receptor positive or negative, because the estrogen receptor positive cancers are the ones that warrant endocrine therapy. That's a pill that you can take. That could be tamoxifen or aromatase inhibitors. You don't need high-level systems to put patients on endocrine therapy. But it's that estrogen receptor testing that has been missing since we first started going to Ghana in 2004. And so we want to create a demonstration project that will make this work. And think of the evidence. Think of what we've learned from COVID. In COVID, when we recognized we had to limit our use of the OR, we said, well, who could we delay to get to surgery? It's the estrogen receptor positive cancers that we could put on endocrine therapy. So if we could get African women on endocrine therapy, because it typically does take a long time to get them into the OR and get that multimodality treatment, that is the highest evidence-based level appropriate. So these demonstration projects are how we're thinking this through. We have a timeline for how we're going to be implementing this over the coming year. We're going to have these meetings of panels. We're forming these working groups for health education, rapid diagnosis, and clinical management, following those strategies that we've talked about of education, creating rapid diagnosis units. That really is an opportunity for public-private partnerships, and creating these cancer management approaches, looking at all of these together. We have to have partnership. Partnership is essential. And so bringing this together is one of the opportunities of the Global Breast Cancer Initiative. And that implementation research, how do we study this? IARC, the International Agency for Research on Cancer based in Lyon, is the cancer research arm of WHO. And they are now moving into implementation research and what we do. The study that we talked about with orphans, that was an example of this. And the UN agencies are bridging together, working together in collaboration. That means WHO, IARC, and IAEA, the International Atomic Energy Agency, which have been so important in doing these impact reviews to study the use of how to implement cancer radiation therapy. So that's radiation therapy. You need to have that type of oversight. So the collaboration among the UN agencies is how this is going to work. So in summary, The UN mandates have now put non-communicable diseases since 2011 on the agenda, and that includes cancer, which is set the stage for change, meaningful change that prior to that time would have been difficult to foresee. Breast cancer is an index malignancy for organizing health systems. It's not just because it's the most common cancer among women, it's also a cancer where we have these great opportunities for improvement based upon tools we already know work. So how do we provide resource appropriate early detection, diagnosis, and treatment? The Breast Health Global Initiative started some of this work. WHO and collaborators can now drive this forward in meaningful ways. Harmonized guidelines, such as this is being done by NCCN and other groups, followed by phased implementation, going in stepwise implementation strategies, driven by implementation research. This is going to provide this framework for systematic improvement in healthcare. And that's why the Global Breast Cancer Initiative can be a catalyst for change by developing these approaches that are relevant to women's cancer and women's healthcare throughout the life continuum. That it's a model, and this can, the same resources that we need for all non-communicable diseases that require longitudinal care. So it's a real driver, and there's huge potential for what can happen here. What I'd like to do is just close with a quote. As I said at the beginning of this, there was this orphan study that IARC had published and it was released at JAM Oncology on December 23rd. There was a wonderful editorial from colleagues in Illinois, and it began with this quote: "Do not look the other way, do not hesitate. Recognize that the world is hungry for action, not words." We have a real opportunity here to act on what Mandela was asking for. It's very meaningful, and it's just fabulous to be able to participate. I again want to thank my surgical partners, my leaders. Doug, thank you for your support in making this all happen. And Dr. Pellegrini for your guidance and leadership. Thank you.
Thank you, Dr. Anderson, for such a fantastic presentation this morning. What a great way to start 2021 for us. I want to open it up for questions for anyone who wants to actually speak and ask their question for Dr. Anderson this morning. We'll start with that. And then once folks have had a chance, then I'll moderate chat if you want to put your questions in chat.
Well, just while the questions are coming, let me just say, Ben, how much I'm inspired and impressed with the work that you and your colleagues are doing. And this was a terrific presentation today, as I'm not surprised by. I admire the work that you're doing, and I think this is such a great example to our residents and other faculty of the impact that we can have as individuals beyond the surgical care that we do. You know, we get the privilege of day in and day out being able to make a big difference in an individual's life. That's a privilege that we have as surgeons. And what Dr. Anderson has and is demonstrating is leveraging that to impacts at a global level on populations and impacts on tens of thousands, hundreds of thousands of people by the type of work that you're leading and doing. So, Ben, inspiring, and thank you.
Thank you.
Can I make a comment as well, Deb? Can you hear me? Okay. Ben, I've commented on your work over the years, but I just have to go back to the first 10 years of this or so when you took this on with a passion, with essentially no resources, some support from the department, but they were kind of on your own. And this is an example of a relentless pursuit of the practical. It's what could be. And, you know, I take what you do and what I do. I try to impact the lives of an individual one at a time. As you're talking about, your one at a time results in potentially millions of lives saves. saved, and mine is in the smaller numbers, sometimes even single digits. And I'm just in awe of your career. I'm just delighted to be your partner, and thank you so much for what you do.
Thank you, David.
We have a question from Susan Marks. She says, thank you, Dr. Anderson, for this comprehensive presentation. In the spirit of the Mandela quote, what actions or opportunities do you see for the department or our health system?
Well, thank you, Susan. I think that's a really profound and important question. And I think I would begin by saying that I've been in the department since 1994, and the Department of Surgery has always had, in my experience, this very broad perspective on healthcare system delivery. And Dr. Pellegrini really had that global perspective and recognized how it's applied throughout. And I think everything I've seen shows Doug carrying on in this same spirit. I think that the opportunities for the Department of Surgery are in continued development of thinking of healthcare systems. That we're really, I'm imagine that others share this perspective, that we're in a time now where our healthcare system is being revamped. COVID is making it happen. I remember a conversation with Dr. Pellegrini back in about 2005 when we were looking at how the systems were not doing well. And he had speculated at that time, maybe what has to happen is the system needs to fall apart so that it can be reassembled. And I wonder if that's what's going to be happening now. Collaboration between the Department of Surgery and the Department of Global Health, I think, is a real opportunity. And training our residents in not just surgical care, but healthcare systems overall. How do we think about finances? How do we take responsible leadership in this area? I think is really important. So the public health sciences linkage to our clinical care will help train our residents and students to be able to apply what they learn in the clinic in these broader environments, whether it be in our hospital or our country or the world.
And that was a fantastic talk, as always. I'm just in awe, as David said, of your career. I really enjoyed it. Thank you. I learn something new every time you give a talk. I think one of the things that struck me is, you're looking at so many different low and middle income countries. They obviously aren't all the same. The cultures are quite different. The acceptance and barriers to entering the healthcare system are different. And one of the things I thought when you touched upon on your talk was the importance of balancing centralization of care in terms of having all the resources in one place versus decentralization and improving access. And how are your teams kind of coming to that decision? And is it different in various places in the world? And how much does the government have a say in which hospitals are actually named the go-to centers and access points as opposed to the providers and patients and the civilians?
Well, thank you, Sarah. That's a great question as well. When BHGI started, one of the concepts we talked about was, we're not going to go fix breast cancer everywhere because that's not really realistic, although maybe there is some potential for that. But cancer is different from other diseases in that you cannot helicopter in, fix it, and leave. So Operation Smile is a fantastic example of being able to go in, you move an OR in, you can change the lives of individuals by doing these single interventions. Cancer care has to happen in country. So our goal is actually not to go fix the cancers in these countries, but rather to provide tools so that the countries can build capacity themselves. It's about health systems strengthening. And what they need is good guidance on how to do that. And that involves the principles that we've been talking about. But ultimately, it is the countries, it is the governments, the policymakers that are making these decisions. And so what we're trying to do is facilitate what's happening. Knowing and analyzing through situation analysis is fundamental so that you're recommending the right strategy in the right environment. Thanks again.
Dr. Anderson, thank you again this morning. We're pausing just a tad early on our questions this morning. In just a minute, I'm going to turn it over to Dr. Wood. I want to again thank you, Dr. Anderson, for being here. I do want to remind the faculty that we do have the semi-annual resident review to follow, and that is at a separate Zoom address. So check your Outlook calendars for that to join us from 7:30 to 8:30. I'm now going to turn the time over to Dr. Wood for a special presentation that we have this morning.
Yeah, thank you, Dr. Marquardt, and thank you, Dr. Anderson, for an inspiring talk. This is a great way to start the year. And I have another great way to start the year. So I'm really thrilled to have a special visitor to our grand rounds this morning. I'm welcoming Dr. Mimi Cabrera. So she's an associate professor in the Department of Ophthalmology. And she is also the chair of the Dean Standing Committee on Women in Medicine here at the University of Washington. And we had invited her here because she has an announcement to make.
Thank you so much, Dr. Wood, and thank you for inviting me. I am truly honored to present this year's UW School of Medicine Excellence in Mentoring Women Faculty Award to a member of your department. This award recognizes the importance of mentoring women faculty and has been in existence since 2003. We have 2 awardees, 1 junior and 1 senior faculty member. When I read the nomination letters for Christine Calhoun, I was absolutely blown away. As all of you are well aware, Dr. Calhoun is a breast cancer expert, chair of the Department of Surgery Women's Council, and the director of the Medical Student Surgery Clerkship. But her contributions as a mentor of women faculty are profound. Dr. Wood wrote, "Chris has been a foundation of our efforts to move the culture of the Department of Surgery to become one that is an outstanding place to develop a successful career with a life balance that supports people of all genders to achieve their full potential, not just as surgeons, but as well-rounded and happy people." Dr. Nicole Zern wrote, "She is one of my most trusted allies in our department, and her advice is invaluable. She has weathered many difficult situations and continues to put others' needs before her own on a daily basis." Dr. Kajal Mehta and Dr. Mahini Dasari wrote, "Her leadership has affected so many of us positively and continues to be a strong force within our department on equity and advocacy for current and future female surgeons." Annie Yang wrote, "Dr. Calhoun served as a guiding light." Ellie Kitchell wrote, "Dr. Calhoun was a voice of reason and enduring support." And finally, Dr. Megan Flanagan wrote, "I truly do not know how she does it all. It's amazing that even though her star shines so brightly, it doesn't dim others, but serves to help illuminate the whole sky." This almost brings me to tears. And what has been a very difficult year for all of us, reading these letters has given the members of Women in Medicine and Science Committee a sense of inspiration and hope. Therefore, it is with great pleasure and a unanimous vote that the committee chose to award this year's UW School of Medicine Excellence in Mentoring Women Faculty Award to Dr. Christine Calhoun. Congratulations.
Everyone go off mute. I want to hear the applause. And Chris, I forced you to go off video mute when you weren't expecting it. So sorry for the surprise, but this is such a well-deserved award for you. And it does bring tears to my eyes, hearing Dr. Cabrera recite those letters from the nomination. Thank you for what you do. This is a great day for breast surgery. We had a great presentation from Ben and a well-deserved and incredible award for Chris.
Well, it's hard to listen to those things. I'm not the type of person who sometimes takes accolades easily, but I really appreciate it. And it really means a lot. So thank you.
Well, thank you, Chris. And I'm just going to make an editorial comment, which is a little different than I normally would, but I mentioned to Ben as we got started, I'm just giddy with excitement today. And I want to share that with all of you. And so I also, my hero for the day, maybe for the year, is Stacey Abrams. So my hat is off and my applause is also to Stacey Abrams and the impact that she's had in politics in our country this year. So this is a good day. Thank you for a good start to the year. This is going to be a better year than last year. And have a good day, everybody.